Okay, so in this section, we're going to talk about sepsis in newborns. Sepsis in newborns is a potential cause of mortality. It tends to progress rapidly. And historically, it's been a cause of quite a few neonatal deaths. And so we want to be able to recognize it very early. When we talk about sepsis, we divide it into early onset versus late onset. Early onset sepsis is usually acquired shortly before or during birth. So this is probably an infection that the mother has that's transmitted to the fetus. That infection doesn't have to be something that causes any symptoms for the mother or causes any severe symptoms. It's just something that's transmitted to the fetus before or during birth. Late onset sepsis is usually acquired in the hospital or in the community. So our preventive interventions are different for those. So early onset sepsis usually manifests within 24 to 48 hours. So this baby is born and they're sick at birth or they get sick very quickly. It progresses rapidly. It has up to 20 to 30% mortality. The most common causes are E. coli and group B strep. There are a lot of other bacteria that can cause it. Some causes that happen that are not as common that sometimes we forget to look for are Candida and herpes. Candida, we think, oh, it's a yeast infection, it's simple, take some diflucan or use some monostat, whatever. But an infant that contracts Candida can actually become septic, and that can be very difficult to treat. And remember that herpes can cause sepsis. So what do? We want to try to prevent transmissions of those to the fetus. The most common cause for a long time was group B strep, and we've actually really decreased that, partly by giving those antibiotics in labor. So remember that patients who are pregnant are usually swabbed for group B strep around 38 weeks. And then if they're positive, they're given antibiotics in labor. If those antibiotics aren't given for some reason and the group B strep status is either positive or unknown, then that baby's going to need to be monitored a little bit more closely for signs of sepsis. Late onset sepsis is usually between a week and 30 days. It's anytime in the first month of life. It can be acquired in the hospital or it can be acquired in the community. Common causes are staph, Klebsiella, enterococci, E. coli, Pseudomonas, and Candida. The bacteria get in somehow. One of the most common points of entry is the umbilical stump, but it can also be through mucous membranes, the respiratory, nervous, urinary, or GI systems. So how do we prevent that? Through cord care, hand washing, cleaning equipment, all those things, okay? The risk factors for sepsis. All newborns are at risk for sepsis because their immune systems do not fight infection effectively. So any newborn that gets an infection is at risk for sepsis. Socioeconomic status, so poverty is a factor, okay? Poor prenatal care, not getting enough prenatal care, which is associated with poverty. Poor nutrition, which is again associated with poverty. Substance abuse, premature rupture of membranes, maternal fever, chorioamnionitis. So if we know that the membranes are infected, we know that's a risk factor. A long labor, especially if the membranes were ruptured for a long time. Prematurity, that premature baby is more at risk. Maternal UTI, the mom has a UTI. There's more than one baby, twins and multiples, and that's probably because some of those other risk factors are increased. Male babies tend to be more likely to get sepsis. We don't know why. Birth asphyxia, that means if during the birth process that baby has hypoxia, has extended hypoxia. Meconium aspiration, that's not because meconium has bacteria that they aspirate, it's because they can develop an infection in the tissue that's inflamed by meconium. Meconium actually causes a chemical pneumonia, and then that tissue can get infected with bacteria. Galactosemia, which is an inborn error of metabolism. They're not able to metabolize galactose. If the baby doesn't have a spleen, which would be a birth defect, or if it maybe had to be removed right away, low birth weight, malnourished, prolonged hospitalization, and invasive procedures. So I want you to look at all those risk factors. Don't just list them and try to memorize them. I want you to look at those risk factors and identify why those babies are at higher risk for sepsis. Okay. Now, what does sepsis look like in newborns? And again, I want you to look at why. When you have these lists of risk factors and side effects and symptoms, don't memorize them. Ask why. So I want you to think for a minute about a newborn that has an infection, and that infection has gotten into the bloodstream. What is going to happen in that newborn's body? So how do we know an adult has sepsis? What are the things we look for? We look for fever. We look for elevated white count. We look for elevated pulse and respirations and low blood pressure, right? So some of those symptoms are from an inflammatory response or the immune system responding. Some of them are because of the infection itself. So newborns have an immature immune system. They're not going to run fever, okay? Newborns don't run fever. So what's going to happen is they're going to have a hard time maintaining their temperature. In the newborn transition lecture, we talked about how energy is required to keep the body temperature stable and to keep breathing going and to handle food. And so if any one of those things requires more energy, it's taking energy away from the others, right? It's like this tripod. Well, if that patient has an infection that's taking energy away from fighting the infection or dealing with the infection, is taking energy away from the other important body functions. So that patient with an infection, that infant with an infection, may not feed well. If they do, they may not digest their food well. They may have a lot of vomiting. They may not breathe well. They may have signs of respiratory distress because their energy is taken out by dealing with the infection, not learning how to breathe because they just came out, right? They may not maintain their body temperature because the energy that would be used to maintain body temperature is being used to deal with the infection. So when we're looking at a newborn for signs of infection, we're looking for signs of respiratory distress, okay? Their breathing is fast, they're grunting, they may have nasal flaring, they may have retractions, they may actually have apneic periods. So their breathing looks unstable, okay? We may see decreased oxygen saturation. And those things may not be because of a respiratory infection. They may happen even if the infection started somewhere else. We may see unstable cardiac status. They may have a fast heart rate or a slow heart rate. They may have hypotension. If their blood pressure is low, they don't perfuse well. And so what does not perfusing look like? They're not perfusing their tissues well. We may see decreased urine output. We may see them being pale. We may see cyanosis because they're not perfusing well. They don't maintain their temperature well, so we may see their temperature fluctuating a lot. If we have a baby, anytime you have a baby that has a low temperature and you don't know why, if they can't keep their temperature up and you don't know why, I want your mind to go to sepsis. I want your mind to think this baby needs to be evaluated for sepsis. So the neurologic system is not getting the energy it needs. It's not getting the glucose it needs because we're using all that to deal with the infection. And so the baby may have apnea. They may have periods that they just forget to breathe. They may be lethargic. They may have decreased muscle tone, so they're floppy and not all tensed or not flexed the way they usually are. They may have irritability and even seizure activity. They may get jaundiced. because their liver can't metabolize stuff because we can't get food in them, and they're using all their energy for other things, so they can't convert that bilirubin. So they may get jaundice, they may be really pale or mottled because of the poor perfusion. They may have petechiae because they may run out of platelets. So think about the things that you're going to see in that newborn, but I want you to go through that list and why. Why is this baby maybe going to have apneic episodes? Why are they tachypnic? Why might they have grunting and flaring? Also understand that every baby with sepsis won't have all of these. They won't have them all at the same time, but they may alternate. They may have different symptoms at different times. So anytime you see any of these things, we need to be evaluating, does this baby have an infection? Prevention for neonatal sepsis: hand washing, standard precautions. Any reusable equipment needs to be cleaned thoroughly between babies. Disposable equipment needs to be disposed between babies, but also it needs to be disposed and replaced regularly when used on the same baby. We don't want to use the same thing over and over and it's dirty. We want to limit exposure to infections. We really encourage parents not to take that baby out to the mall the day it's born or the day they get home from the hospital. We want to avoid things like touching the baby with dirty hands. We don't want people kissing the baby that may have cold sores. Think about limiting exposure. Newborns can get a bath with warm water and a mild soap, but we don't want to scrub off all the vernix, because that vernix helps establish healthy skin flora, which can help prevent infection. There's no support for putting anything on the cord site. The most important thing we can do for that umbilical cord site is keep it clean and dry. We used to clean it with different antibiotics. Some facilities still paint it with triple dye, which has got antibiotics or antiseptics in it. Some places still clean with alcohol, but there's no research supporting that. What the research supports is just keep it clean and dry. Don't put things on it. Dries up, falls off faster. Eye prophylaxis is given to prevent eye infection that could lead to sepsis. And then we want to prevent and treat maternal infection. So if they've got an STI, we want to treat it. If they've got yeast infection, we want to treat it. If they have GBS, we want to treat it. So preventing and treating those maternal infections. Management of sepsis, the absolute most important thing is recognizing something is wrong early recognition, and then cultures are obtained. Antibiotics are given immediately, because if we wait until cultures come back, it's too late. So they're going to, if they suspect sepsis, they're going to do cultures. They probably will do blood cultures plus culture anywhere else that they think the infection might have started. And then they're going to begin antibiotics immediately. Okay, so the most important part of management is early recognition. They're going to get cultures and then start antibiotics. We don't really need to be waiting around for a long time to get those antibiotics going. So we've got those cultures are stat and the antibiotics are stat. Cultures are going to be more accurate if they're done before antibiotics are started, but we can't wait for an hour for them to come draw cultures and then start our antibiotics. So the cultures are stat, antibiotics immediately after, and then supportive care. We want to make sure that that baby is getting, if they need extra oxygen, sometimes they actually need some ventilatory support. The sickest babies may actually need support to maintain perfusion. So supportive care and treating that infection. And then we want to use transmission-based precautions to prevent giving that infection to other infants. Okay, the next section is going to begin preterm infant. There are several sections on the preterm infant because there's a lot of things you need to know.